Hello, good morning to all. I'm Dr. Sebastián Frias, and me, in collaboration with María Jesús Figueroa and Daniela Martinez, made a seminar about neonatal resuscitation. That seminar with simulation was very effective, and now we're going to try to make an online class about the theoretical part in order to be prepared and be able to study before the simulations for the next years. So this presentation is going to be about primary neonatal resuscitation. When a baby born, it's a moment of big changes, and the risk of having a cardiorespiratory arrest or having some difficulties in the process of adaptation to the out-uterine environment, it's high. Actually, 7% of the newborns need some resuscitation maneuver, so it's very good and very important for us to know how to do it, because with a simple steps we can save lives. Now we're going to talk about the steps. But first, the root of this presentation, we were going to talk about a little bit of physiology of the newborn and fetal physiology, because knowing that, we will understand the concepts in the resuscitation and the explanation of why we do the things that we do. We're going to talk about the perinatal mortality here in our hospital in Bagari, and what we're going to talk about what things we have to do and we need to have prepared before the reanimations in terms of resources, material resources, and in the human team. Also, we're going to talk about in the moment at birth, how do we approach this newborn? We need to ask ourselves one question at the beginning, and also if the baby needs resuscitation, we need to make 5 actions, coordinated actions that I have to think by my own and make them with my baby. Then we're going to talk about more deep about the positive pressure ventilations and how to check that I am providing a very good, high quality positive pressure ventilation with the Mr. Sopa, and what to do in all of the situations that we can have during our reanimation. The decisions during the reanimation we take in order of the heart rate. So we will say what to do when the heart rate is above 100, when the heart rate is between 160, and when the heart rate is below 60. All of that are the different things that we have to take, take decisions according to the heart rate. And all of that is summarized in an algorithm that we're going to check at the end of the presentation, like to make a summary of all and have all on our mind. So first, it's important to know that before the delivery, the lungs of the baby, of the fetus, doesn't work. They are very little and without blood circulating. The blood of the baby is oxygenated in the placenta, here. So the placenta works as a lung, the placenta works also as a kidney, the placenta works as a liver, make all the functions for the baby. And the placenta comes from the blood, the oxygenated blood comes from the placenta in the placental vein, in the umbilical vein, and go through this way, until reach the heart. And from the heart, it is pumped to the rest of the fetus. In that moment, the circulation have 2 important shunts, the ovale foramen shunt and the ductus arterius shunt. But after the birth, when the baby birth, these shunts closes. Okay, so here we have the ovale foramen shunt that is from the right atrium to the left atrium, and the ductus arterius shunt that is from the pulmonary arteries to the aorta. So these shunts allow the circulation to stay like a fetal circulation, okay? And the fetal circulation bypass the lungs because the lungs are not working. So in the moment of birth, the lungs fill of air when the baby takes the first breath, and the oxygen concentration in the blood increase a lot. So that the increase of the oxygen concentration makes these shunts to close, because the shunts have like oxygen receptors in the cells that are there, and that oxygen receptor make the muscle cell of the shunt to close. So that is very important, and that explains why we need to give positive pressure ventilation when the baby is not breathing, because that expands the lungs and start the circulation of the fetal circulation to change and transform into a systemic circulation. In the systemic circulation is the circulation that all of us have, and it's a circuit from the heart to the lungs. The lungs increase the oxygen in the blood, then return again to the heart, and from the heart to all the body. And the blood is in all the body and then come again to the heart to be pumped again to the lungs. That is a very big difference. So here in the fetal circulation, in summary, we have that the placenta is the main organ that gives the oxygen to the blood, and we have two shunts that make a short circuit in all the circulatory system, and this short circuit works only when you are inside the uterus. When you are outside the uterus, you need to close this short circuit in order to make the lungs work. And how we do that? Increasing the oxygen concentrations in the blood. So that makes a closure of the shunts. So that explains how we have to give the positive pressure ventilation that we're going to talk about later. So can you guess how many newborns died in Bagari? The average is between 2 and 5 newborns per day. And that means that between 14 and 35 newborns in a week. Or it can be a number like 56 at a month. And the causes are very different causes, but there is a cause that is the most common. Which cause of these ones do you think is the most common cause of neonatal mortality? Here we have the preterm deliveries, that is the most common cause. And but also the preterm deliveries are related to other things that combined can be the responsible of the neonatal mortality. For example, infections, for example, perinatal asphyxia. Here in Bagadi we have a situation that sometimes we have very big babies that are not preterm, that weigh, for example, 2.5 kg, but they have very bad Apgars, and that is because we have perinatal asphyxia, and that thing is very preventable. So in the developed countries, the most common cause of neonatal mortality is malformation, because this you cannot prevent, and it's a thing that you cannot treat when it's installed in the baby. You cannot treat it. So the neonatal mortality here in Bagadi, I think, is more because of preterm babies and perinatal asphyxia. The perinatal asphyxia, we can prevent it with a very good resuscitation and very good management of the intrauterine fetal status. So if you have a non-resumed fetal status, we have to give intrauterine resuscitation. We have to have a prompt C-section if we need it. And in order to prevent the preterm deliveries, we need to give the corticoids on time if we have to. We need to also treat the asymptomatic bacteriuria and all the risk factors of preterm deliveries. So these are things that we can prevent, and that is the reason why in developed countries these are not important cause of neonatal mortality. So this is my first question that I have to you. What do you need to have prepared before a reanimation? So before performing a very good reanimation, you need to be prepared. Now, I want you to take a white paper and write down all the things that you think that you need to have prepared for the reanimation, and then we will check if you have the correct answer. We are talking here about material resources, but also the human resources. So you have to write down all of that. So here is the answer about the material resources. We need a heating cradle, of course, because one of the important parts of the reanimation is to prevent the hypothermia of the baby. A timer, because we need to take the time correctly. An algorithm about how do we have to work, like the information, because we can forget some things. Suction machine and catheters of different sizes depending on the gestational age of the baby. Oxygen, of course, and the mask, depending also in different sizes. A self-inflatable bag ventilator to give the PPV, adequate mask, clothes and towels, pulse oximetry for monitorization, and a stethoscope. This list is like the minimum of things that we need to have, but of course you can have more things if you want. And here we have, like in this photo, all the things. Here is the AMBU, the ventilator, the positive pressure ventilator. Here is the cradle with the heater, the clothes, yes. Here we have aspiration and oxygen in the wall. So all the important things must be prepared, and the person who is in charge of the reanimation must know where are all of that things. And of course, there are some things that I didn't put here, but it's important to know that sometimes we need drugs like adrenaline, and that things is more advanced resuscitation, and this class is going to be about only the basic neonatal resuscitation. That's why I didn't put the adrenaline or the catheters, the umbilical catheters, etc. And in addition of the material part, we need also the human resources. Human resources are very important because you need to be coordinated and you need to have distributed the functions of every person before the reanimation. Because when the reanimation occurs, you need to be prepared. You cannot start like distributing the function and talking about how you will work while the baby is in an arrest, in a cardiac arrest. So you need to have this spoken before. So the minimum of person for a reanimation must be 2, but the optimum is 3. So that's why here we are talking about 3. So it must be a leader first, that is a person who knows very good the algorithm and how to perform a reanimation. This person must have this characteristic, verbalization, that is to say everything that he thinks, because the other cannot read his mind. Also, he is going to be in charge of the airway management, so he needs to know how to open the airway and how to give the ventilations. He is going to take the decisions about what to do with this patient, and he will distribute the functions between the assistant and the time person. The time person is going to be the person that takes the time, so he needs to have a clock or a phone prepared for that, and he will be the person that will remember every 30 seconds to reevaluate. This is the most important function because the leader has to be focused on all the other things, so he can forget when to reevaluate. And the time person will be the person that will remember him. Also, have to measure the heart rate and to listen the ventilation every time that he reevaluates. So check the chest rise when the ventilation occurs, and all of that. And the assistant is a third person that will be bringing all the necessary for the reanimation and will be prepared to ask for help if the leader needs help, go for help, and help in everything that the leader asks to him. He also will make the chest compressions if it needed. And of course, there are some situations that are not the optimum, that you can be alone and you have to make the resuscitation alone. In that situation, you have to be the leader. So the most important here is to provide the good positive pressure ventilations. And if you have to perform positive pressure ventilations and compressions, you need to make the compressions with your 2 fingers. We're going to show how to do that. So now we are in the moment of birth. So this is very common. In Bagari, born like 40 or 30 babies in a day. So when a baby born, which are the 3 questions that you need to ask in the beginning to yourself to select this patient, like this patient will need resuscitation or this patient will not need resuscitation? You have to perform to yourself, you have to ask yourself 3 questions. And if one of those 3 questions is not good, is a response that is not good, you need to take the patient for a resuscitation. So which are the 3 questions? Please try to write down if you have an idea, and then I will show you the answer. So these are the 3 fundamental questions to know if the baby will require or not the reanimation. So term gestation, this is the first. All the babies that are preterm, you need to perform the reanimation, the beginning of the reanimation only, to be assured that the baby is okay. You cannot give to bonding immediately. You need to perform a little reanimation. That is, maybe you don't do nothing, but it's to do the 5 important first things. And the second question is if the baby is breathing or crying. And the third question, does the baby have good tone? So if all of these three questions, the answer is yes, I'm saying the baby is term gestation, is breathing and crying and have good tone, it means that we can send the baby to the mother for bonding. So infant stay with the mother. But if don't, if for example the baby is only preterm, is breathing and crying with good tone, but is preterm, or for example is term and is breathing and crying but it have a bad tone, you give the baby for reanimation. Okay? Any one of these, if only one is bad, the answer is no, you have to lead the baby to reanimation. And how to remember these three questions? There is a little mnemotechnic that is the 3G. 3G. So the 3G, that is gestation, good crying, and good tone. Good breathing and so now that we have selected our patient that will need resuscitation and the patient that will not need resuscitation, we have to start the resuscitation with this one that need the resuscitation, and we have to start the resuscitation with five things that we have to do. Which are these 5 things that we have to do? I am doing again this question. Please try to write it down, and I will show to you. Okay, so the 5 things that we have to do when we start the resuscitation is to warm the baby. So we bring to the heater, to the cradle heater. It has to be turned on. Open the airway. We will show which maneuvers we have to make to open the airway. Clear secretions. Also to clear all the secretions that can be in the mouth or in the nose. Dry and stimulate after the clearing of the secretions. And heart rate measuring. The clearing of the secretions must start in the mouth and then in the nose, because if you do it in the beginning in the nose, you can stimulate to the baby to aspire all the things that are in the mouth. And also, if there is meconium, you cannot stimulate before clearing the secretion, because you need to clear all the meconium that is in the mouth and in the pharynx. So these are the 5 things that we need to do. And we finish with the heart rate measuring. This, we have to do it very fast. So we do these 5 things in the first 30 seconds. And before the 30 seconds end, we need to have measured the heart rate, the newborn heart rate. And how we measure it? Of course, we cannot measure during 1 minute and then say, oh, it's 120 in 1 minute. No, we have to measure in 6 seconds how many beats the baby have in 6 seconds, and then multiply it by 10. So that we will say you an approximation of the real baby heart rate, and we don't lose time waiting until 1 minute. Okay? And why is important the heart rate? Because that will make us to select the patient if we need to continue the reanimation, or we can give the patient, the baby, to breastfeeding. So you know who is this person? This is also another Chilean football player that is called Arturo Vidal. He's playing in Barcelona. So we need to learn how to make a very good resuscitation, because the babies that we will save maybe can be very good football players and can make Kenya be a very good football team. Because we know that Kenya is not very good now, but Chile also was very bad like 20 years ago. And now we're a very good football team. So I hope Kenya can be that. So let's put in this situation. After 1 minute, after the baby born, we have 1 minute. In this minute, we do the 5 important things: aspiration, stimulation, opening of the airway, measure the heart rate, and warm, all of that. We do all of that. And then after 1 minute, we check the heart rate. And the heart rate is up to 100. What we have to do? We leave the baby with the mother for bonding and breastfeeding, because the adaptation of the baby is doing well and it doesn't need more further resuscitation. By the other way, if the heart rate is less than 100, or the baby doesn't breathing or shortness of breath, have some difficulties on breath, what do we have to do? PPV. What means PPV? Positive pressure ventilation. Okay, to do that, we need to put the baby in a sniffling position, because in that position we can open the airway. So we pull a little up the neck, make a little of hyperextension of the neck, and of course we can put something behind the shoulders in order to pull a little up the thorax cavity. So we need to give ventilations saying Pumoa 1, Pumoa 2, Pumoa 3, Pumoa 4. That is like the frequency. And while we give the ventilation, we need to see the chest movement, the chest rising, to ensure that we're doing a very good ventilations. And don't forget the thing that I say of the timeman. The timeman must remember all the time to the leader that every 30 seconds we need to count the heart rate, because that can change us our conduct. That can change the things that we do. If after 30 seconds the heart rate is now above 100, we stop the ventilations. Or if it's below 60, we have to start chest compressions. So it's very important to have the information of the timeman. So the recommended ventilations, the frequency, is between 40 and 60 per minute. That is why we have to think like Pumo 1, Pumo 2, Pumo 3. Because sometimes you can be nervous, you can be anxious, and you can start giving the ventilations very fast, like the chest compression, like 1, 2, 3, 4. But that is not the recommended. You need to open the lungs, give the pressure, stay a little bit, and then close. So that is the reason why we use that mnemotechnic words. In the algorithm, is with Bagadi. So you can say Bagadi 1, Bagadi 2, Bagadi 3, Bagadi 4. Okay? And why is very important the PPV? Because in difference, in the opposite of the cardiorespiratory arrest of the adult, here the cause of the cardiorespiratory depression, like the cause of the bradycardia of the baby, is the hypoxia, because the lungs are not working well, are not expanding well, and that is very common in the newborns. So when we give the positive pressure ventilations, we give a help. We help a little bit to open the lungs, and that will start all the adaptation process that I told you in the beginning about the closure of the shunts, about the circulation and the increase of oxygen concentration in the blood. So that will provide the baby to start by himself, like the adaptation process. Okay? Approximately the 90% of all the babies that need reanimation can solve the problem with the PPV. So if we have 10 reanimations, 9 of them can be solved with only PPV. So it's the most effective measure that we have to do when we have babies that are depressed. So I always stimulate and repeat the suction if it's necessary. So now I'm going to show you a video about the Mr. SOPA acronym. This is an acronym that we need to use when we are giving the positive pressure ventilations and we think that the baby, that our PPV is not doing correctly, that we're doing something wrong. So our ventilations are not effective. And we have to remember the Mr. SOPA acronym. Now this video will explain you better.
If the newborn's heart rate does not rapidly increase after beginning positive pressure ventilation, you must determine if you are providing effective ventilation. Ask your partner if there is perceptible chest expansion when you deliver a breath. If the newborn's heart rate is not improving and you do not see perceptible chest expansion, you need to take corrective action right away. The 6-step corrective action sequence can be easily remembered using the phrase Mr. SOPA. Each letter in this phrase stands for a different step: mask adjustment, reposition airway, suction, open mouth, pressure increase, and alternative airway. Let's
Okay. So this is the Mr. SOPA. The first is mask tightly applied to the face. So if the baby is preterm, you need to use a little mask If the baby is term, you need to use the term mask. Reposition of the head, that is the sniffling position that I told you. And if you're not with the cloth in the back of the shoulders, you need to use it because that can help you a lot. Suction of the nares and the pharynx. Open the mouth. Sometimes you give the ventilation with the mouth closed, and through the nose it's very difficult to give the ventilations because the airway of the baby is different than the adult. Pressure, because maybe the positive pressure ventilation, the pressure is not so high, so you can increase it that moving the valve of the AMBU self-inflatable mask. And the alternative airway. That is when you think that all of these ones, the previous ones, are okay and you really don't have an airway, but for the alternative airway, you need to call a specialist. And also you need materials, the endotracheal tube and all of that. So that situation, it's only when you have the health resources trained and also the materials. That is not the situation of Bagari. Now we're going to show a video about a test of the simulation about neonatal resuscitation here in Bagadi 2 years ago, and I think we will do the same. So it's only for you to know how we do it and to check the Mr. Sopa, to remember the Mr. Sopa.
Adjust my mask and make sure it's airtight.
Very good.
And then I reposition. I just check whether my airway is open. And then I continue. If there are any secretions, I'll suck the pipi, the mouth and the nose, just to make sure the airway is open.
Perfect. You can do a deep suction also, right?
Yeah, at this point a deep suction. But I'll go in without the pressure. When coming out, I'll put
with
the
pressure.
There.
Perfect.
So I continue. If still not rising, I'll increase my
The pressure.
pressure. Yeah.
Very good. So let's see it now.
The pressure.
Pumo 1. Pumo.
Okay, now we're in the situation of the heart rate is below 60. Okay, but this is the little letter after 30 seconds of the effective ventilations. What do we have to do when the heart rate is below 60? Chest compressions. Okay, so here we have an image about how to do the chest compressions. It needs to be with the both thumbs in the chest of the baby, between the nipples, and you have to compress 1/3 of the anteroposterior diameter of the thorax. Okay, and you give that with the ventilation. So you do and 1 and 2 and 3 and ventilate, and 1 and 2 and 3 and ventilate. Okay, so 1, 2 and 3 are chest compressions, and then after that you give 1 ventilation. The thumb technique is only when you have an assistant. If you're alone giving the ventilations and the compressions, you use your 2 fingers, but it's a not so effective technique. Okay, you do that until the heart rate go up to 60. So you have to check it every 30 seconds, and if after that it's above 60, you stop the compressions and continue only with the ventilation. Okay, it's very important, this thing that I say to you, because some babies can born depressed with heart rates like under 60, for example 55 or 40, but they haven't had positive pressure ventilation. And as I said you in the previous slide, the positive pressure ventilation saves the baby in the 90% of the time, because the cause of the bradycardia is the hypoxia. So when you give good ventilations, the hypoxia resolves and the bradycardia resolves. So the chest compressions are only reserved when the situation when you have below 60, but after giving 30 seconds of PPV, okay, and of effective PPV. If you give PPV and you realize by your Mr. Sopa that your mask wasn't good adjusted, you change your mask and then you do 30 seconds again. And after the 30 seconds, if you continue with heart rate below 60, you start the chest compression. Preterm delivery considerations. When we have a preterm delivery, we need to know a few things. Okay. The first one is that the ventilation must be soft, because the lungs are very easy to break. So you need to compress the half of the chamber. If you have a non-pressure measurement chamber, you compress the half of the chamber, and use an adequate mask for the ventilation that fit very good in the baby's face. adequate size of suction catheter, and the compressions in the anteroposterior 1/3 of the thorax. Okay, and you have to be prepared before. So what to do after the resuscitation? When we realize that the baby heart rate is above 100, the baby has good respiratory effort and no cyanosis, we stop resuscitation and give the baby to the mother. So the baby can start the bonding and breastfeeding. So this is the post-resuscitation care. These babies have a little more risk than a normal baby because this baby needed resuscitation a few minutes ago. So it's important to check up the baby, the status of the baby, every 5 minutes continuously. And you cannot leave the baby alone. You have to call an MO and someone in the on the NVU to check the baby, to make a diagnosis about the status, the general status of the baby. And of course, you need to put the baby near to oxygen. So you give free flow of oxygen near the aerial entry, near the nose or the mouth, in order to help the baby a little bit with the oxygenation of the body. After the reanimations, this is a part that all the people forget, and it's very important because if we don't do this, this can make it worse the next reanimation. We have to clean the area and order all the materials in their original place, because it must be an accorded place for all, in where we have to save the self-inflatable bag, in which we have to save all the different things, including the drugs. So we need to, after the reanimation, order the place and put the things, all the things in the place that they belong, and make all preparation for a new resuscitation in the future. And what about the relationship between the people that work in this? It's very important here, the leadership and the communication, because we only have 2 hands and 1 brain. We only have 2 hands and 1 brain. And for this, we need more hands. And also, if there are more brains that can help us to check the time, for example, or suggest opinions, it's very important. So why is important the good communication? Because alone we cannot work in this kind of situation that are emergencies, that we need to act fast and think fast. What can happen if you don't verbalize? The others cannot read your mind. They cannot read your mind. So you need to say the things that you are thinking. And why do we need a leader? Because we need someone who distributes the functions, who gives the orders. If no one is a leader, we can have problems. So here the important message is the communication. We need to communicate between each other, and the communication doesn't have to start when the reanimation occurs. The communication must start before, in the moment that we prepare together. We say which our functions, what are you going to do, what I'm going to do you have to prepare all of these things, and all of that. So it's very important, the communication, and very, very important, the communication between the leader and the time man. That is the most important part. So in summary, the take-home points of this presentation is that it's a must to know the neonatal life support skills, because that can save lives. It is always better to ask for help and to distribute the functions between all the people that are going to help you. The important message, the most important things of this class is that the PPV, the effective PPV, save lives, okay? Because this is a very little measurement, a very simple thing that we can do that can save the 90% of all the babies that born depressed. And of course, the teamwork and leadership and verbalization of actions are very necessary, and also can save lives. Here we have a summary of the algorithm about the neonatal resuscitation. So only to make a summary of all the class, what we have to do. A baby born, okay? We have to ask ourselves the 3G, the term gestation, the baby have good breathing or crying, the baby have good tone. If all of this is yes, all of the answers are yes, there's no need of resuscitation, the baby stay with the mother. That is the most common. But there are 7% of babies that one of these questions is no. One of the answers of this question is no. So what do we have to do initially? In the first minute, we have to warm the baby, open the airway, clear the secretions, dry and stimulate, and measure the head rate. After all of this, we will know the heart rate, and also we will check the respiratory pattern of the baby. So if the heart rate of the baby is below 100, or the baby have apnea, is not breathing, or is gasping with difficulty in breathing, we have to start providing the positive pressure ventilation. So we give with an AMBU, Pumo 1, Pumo 2, or Bagari 1, Bagari 2. We give the ventilations, okay? If the answer is no, the conduct here is to start the post-resuscitation care. So we put the baby near to oxygen, check every 2 minutes, and after that every 5 minutes, and call an EMO to check the baby. But we can give the baby to the mother to bonding and breastfeeding. By the other way, if we give the positive pressure ventilations, we don't have to forget that we have to check the heart rate after 30 seconds. So if one of that moment the heart rate is below 100 after 30 seconds of positive pressure ventilation, what do we have to do? Again, check the chest movement to check if we are giving correct PPV, ventilation corrective steps, that is all the Mr. SOPA. So we need to check our mask adjustment, the reposition of the airway, okay, suction, open the mouth, okay, and increase the pressure. And if after that we realize that the chest is rising and we are giving correct ventilations, but the heart rate continue below 60, we need to start the chest compressions. And how do we perform the chest compressions? We coordinate with the ventilations. So, and 1, and 2, and 3, and ventilate, and 1, and 2, and 3, and ventilate. That is the correct way of giving the ventilations. Okay? Yeah, and after that, every 30 seconds, we need to check again the heart rate. If it's below 60, we continue with the chest compressions. If it's above 60 but below 100, we have to do the part of here. So, check again the ventilation and provide positive pressure ventilation. After 10 minutes of resuscitation, if the baby continue with the heart rate below 60, it means that you don't need to make more effort and you are on the limit. But here in Bagari, there's some situations that you can also continue the resuscitation for more minutes, and it also depends on how is the mother, what does the mother want, but you have to explain the mother that if the heart rate is below 60 and you have been 10 minutes making the resuscitation maneuvers, it will be very difficult to save this baby. So in this part you have to be more with the mother, try to support her, and also try to give the information in the best way possible. So here we have a video of the neonatal reanimation of a university in Cambridge. I want to show you this because this is not a real reanimation, it's only a simulation, but it shows very good how do you have to work like a team, how to verbalize all the things, and also if we make a test to you about simulation, you have to do the things the same than here. So please pay attention, and after the video we will finish the class.
Neonatal resuscitation. Initially dry, warm, and stimulate the neonate, removing wet blankets as necessary. Warm the environment if possible and minimize drafts. Observe for color and unlabored respirations. Suction the neonate's mouth with a bulb syringe 2 to 3 times and follow with suctioning the nose. Always suction the mouth before the nose. If the nose is suctioned first, the neonate may be stimulated to take a breath and may inhale any fluid or secretions that are in the mouth. Assess the heart rate at the umbilical cord or the brachial artery. A normal heart rate is between 120 and 180 beats per minute. If the neonate's heart rate is less than 100 beats per minute and appears to be gasping for air, take the following steps.
Heart rate 50 beats per minute.
Shallow breaths, maybe 20 breaths per minute.
Make sure the airway is clear and begin monitoring SpO2. Initiate positive pressure ventilation. Squeeze the bag only enough to see the chest rise. Continue assisted ventilation until the neonate is taking 40 to 60 breaths per minute, unassisted, and maintains a heart rate of at least 100 beats per minute. If the heart rate of the neonate is less than 60 beats per minute, start chest compressions.
1, 2, 3.
2 people are required for CPR. Use the thumb encircling method at the lower portion of the sternum between the nipples. Depress the chest only a half to 3/4 inches and allow for complete chest recoil between compressions. Continue at a compression to ventilation ratio of 3:1 with a compression rate of 100 compressions per minute. Reassess the heart rate. If the neonate's heart rate is greater than 60 beats per minute, stop with compressions and continue with ventilation.
Heart rate is 80 beats per minute.
If the heart rate remains less than 60 beats per minute, intubate and neonate and consider epinephrine.